Okay.
No, not yet.
Okay, let me go off and try and reach you.
My sincere apology. I'm not sure what happened there. Just the network just went down in where I am. But I'm back on now, so I'm not sure where you last heard me, or if I should continue, or you've begun something else.
Sorry about that, Dr. Della. Please, you can continue.
Can you tell me what the last thing you heard from me?
You were trying to summarize the this part also. So if we can quickly just give a summary of what we've mentioned so far and then continue, that'll be great.
Thank you. So I think I've gone through the slide already and highlighting the key players in the transition between the fetal and the adult circulation. I've spoken about the role of the placenta in oxygenation and the production of prostaglandin. I've spoken of the role of the ductus venosus, the foramen ovale, the ductus arteriosus, and the role of the lung in the destruction of the prostaglandin. I highlighted the three important shunts in the fetal circulation, spoken about the roles they play individually, the ductus venosus, the foramen ovale, and the ductus arteriosus. I played a bit of emphasis on the things that sustain the ductus arteriosus, i.e., the relative hypoxemia of the fetus, the high production of prostaglandin by the placenta, and the relatively low metabolism of the prostaglandin by the non-functional lung. And so with that, all three shunts contribute to sustaining the circulation that ensures that oxygenated blood primarily goes to the head and the neck, and then deoxygenated blood goes primarily to the lower limbs of the body. I've spoken about the events at birth that trigger the switch from the fetal to the adult circulation or the neonatal circulation. And important is the removal of the placenta, which I say eliminates the prostaglandin, which is important for maintaining the ductus arteriosus, and also elimination of the placenta fetal oxygenation, which leaves the ductus venosus as being irrelevant. I've spoken about the clamping of the umbilical vessels, which increases the systemic vascular resistance. That in the long way helps in the closure of the ductus arteriosus. I've spoken about the lung expansion from the first cry of the fetus, of the first cry of the baby, which causes reaeration of the lungs and reduction in the pulmonary vascular resistance, and increase in pulmonary blood flow, the increased destruction of prostaglandin, and the switch from a hypoxemic environment to an oxygenated environment, and how all these three contribute to the closure of the ductus arteriosus, as well as the closure of the foramen ovale from the increase in left atrial pressure when the pulmonary blood flow increases. So I ended up talking about the fate of the various shunts, and then we talked about key differences
Hello, Dr. Della, please, we are unable to hear you.
Hello, Gordon. Hello, Gordon.
Hello, Asian.
Hello.
Hello, please, Asian. Can you hear me? Hello?
Hello, Gordon.
Yes.
Hello.
Hello, Asian. Can you hear me?
Oh, what's wrong? Okay, Gordon, if you can hear me, his network is very bad, and so he's trying. So for you can go back to your MCQs. We are trying to see if we can rectify it.
Okay, sure. Okay, sure. Thank you. Question number 26 to 30 is to be taken by Dr. Pernejo. Pernero.
Good evening, Dr. Badams. It's freedom.
Good evening, please, you can go ahead.
Okay, good evening, all. I'm taking question 26 to 30. For 26, they say a 50-year-old white female non-smoker without history of cardiovascular disease and treated only with peripheral hypertension was hospitalized for unstable angina. The ECG revealed C-wave inversion in the lateral leads. The medical student who admitted the patient asks you what is the proportion of patients that undergo coronary angiography for ACS who have non-significant coronary artery disease. Option A says less than 5%, B 10% to 15%, C 20% to 30%, D 25% to 35%, and E 30% to 40%. So from my research, I got that the proportion of patients with with the portion of patients who undergo coronary angiography for ACS with no obstructive coronary artery disease, the term referred to as MINOCA, myocardial infarction with non-obstructive coronary artery, it varies. And from my search, what I got was that it's 10 to 15% of the patients that undergo coronary angiography for ACS that does not have coronary artery disease. However, when I went through this book, the answers, their answer they gave they shows option C. However, like Dr. Bassi highlighted earlier, sometimes their answers, you see, their answers differs from what their explanation is. From the explanation in this book, they said in a study done amongst about 5,767 patients with NSTMI. It said the patients were enrolled. Okay, patient had unstable angina. Then about 88%, they were all subjected to coronary angiography, 88% had significant coronary artery disease. That's those having significant coronary artery disease described as those having stenosis greater than 50%, and 6%, about 6% had mild coronary artery disease. Then 6% had no stenosis. Then the study also found that 12% had non-significant coronary artery disease. That's the explanation that they give. However, they shows option C, which is 20 to 30%. Going by the explanation, I think that 10 to 15% that I got from my research is like to be the right answer for this question. So for option 26, it's 10 to 15% of patients that undergoes coronary artery angiography for ACS that have non-significant coronary artery disease. So question 26, the answer is B. If there are comments, contributions, we're welcome at this point. Then for question 27, a 59-year-old man was successfully treated with PCI for NSTEMI. During the procedure, the patient received bivalirudin. Then due to closure device failure, the patient suffered a major bleeding at the access site, which was difficult to control with manual compression, and you are in need of reversing the anticoagulation. Your treatment of choice is A, fresh frozen plasma, B, proton beam complex, C, epsilon amino capuric acid, D, protamine, E, vitamin K. Please, from this option, we know vitamin K is antagonist for warfarin, protamine sulfate for enoxaparin. Bivalirudin is a synthetic direct thrombin inhibitor, which is derived from hirudin. It is said that it doesn't have a specific reversal agent. In order to manage toxicity from bivalirudin or bleeding caused by bivalirudin, there's no antidote that's available. However, it has a short half-life of 25 minutes, which is said to be longer in renal patients because it's excreted by the kidney. Patient that has renal impairment the half-life is longer because it's excreted by the kidneys. Its effects said to wane within 1 to 2 hours after stopping its use. So in managing patients that have toxicity from bivalirudin, the main reversal strategy is to discontinue the bivalirudin infusion. Then there are other supportive measures, which includes mechanical, surgical hemostasis if possible. Then transfusion of blood products like PACs, red blood cells, platelets. Then it's said that dialysis is not effective in these patients. However, in a study done by I think Irani, they said a patient that was that's Irani et al. They demonstrated that they had a clinical experience which suggests benefit from proton beam complex concentrates, utilizing the effect of R-hirudin, which is a synthetic direct thrombin inhibitor. Okay, this bivalirudin is synthesized from hirudin. So from their study, they said patients with bivalirudin toxicity benefits from proton beam complex concentrates. The mechanism of action of this proton beam concentrates in patients with bivalirudin and toxicity is one, it is thought to regenerate additional thrombin, and we know bivalirudin is direct thrombin inhibitor. It's also said to contain some additional clotting factors, like those vitamin K dependent clotting factors 2, 5, 7, and 2, 7, 9, and 10, rather 2, 7, 9, and 10, which are thought to be thrombogenic. They have thrombogenic effects. So with this effect, it is said that proton beam complex helps to stop bleeding induced by bivalirudin. So the answer to question 27 is B, proton beam complex. Then for question...
Sorry, good evening. Sorry. My network went off a little. Is the option
Okay.
C relevant for anything, please? The epsilon and minus, is it relevant for anything, please? Thank you.
Actually, I tried checking. I didn't really see anything that's relevant for. I checked.
Okay. The FFP. In which group of on what condition can we give the FFP?
For FFP, in fact, from what I saw, when I checked online and all that, in fact, they were suggesting that FFP is better for these patients. However, for the options, it shows protein complex. And they try to describe the same thing that will achieve with FFP. They say FFP is also thought to help to produce factor 2, 7, 9, and 10. However, going by the fact that the book is what we're using, probably those that wrote the book would have done some research. That's why I'm going for this. It's not ordinarily from my research. I thought FFP is supposed to be the answer, but it's still the same explanation given for FFP that they also give for protein complex. However, this was done. There was a study or done by some persons where they found that protein complex is useful in patients with the value within toxicity. That's why I decided to go with that.
Thank you.
Welcome. So for question 28, Dr. Gordon, please, can you go up in this? Okay. For question 28, a 63-year-old man presents typical chest pain at moderate exertion in the preceding month and is admitted to the hospital for coronary angiography. While considering the best access for the procedure, which of the following statements is not correct regarding a radial vascular access? A. The radial vascular access may be useful to decrease access site complications. B. The radial vascular access is preferred in patients with coagulopathy. C. The radial vascular access is preferred in patients with morbid obesity. D. The radial vascular access is preferred in patients with an elevated INR. E. The radial vascular access is more frequently performed in the United States than in Europe. The common vascular access used in patients that are going for coronary angiography and the radial vascular access and transfemoral access going through the groin. But it's thought that the transradial approach is increasingly the default and recommended access method, which is safer and it offers a lower risk of bleeding and leads to shorter bed rest period, and the patient, because they have that benefit of having lower risk of bleeding, even for the fact that it has lower risk of bleeding, patients that undergoes that has patients in whom radial access is used for, they tend to ambulate faster, and so they tend to discharge them earlier than patients that whom transfemoral approach is used for. And because for transfemoral approach, there's this complication that arises. I think that we've seen in Brownwood's, also in Brownwood MCQs before, where you have to ensure that you get the access above a certain point, so that you can, in case there is a bleeding, you can apply pressure pressure on the femoral artery in an area close to the head of the femur. Then with that alone, for patients that are obese, you want to go through that approach, because for a patient that is obese, for even location of the artery, as me you want to even do a procedure, there is a problem. So those are the kind of patients that you want to use femoral access for. So with that, option C is wrong. Then, like I mentioned earlier, it is the recommended, as like I said, it is recommended access because it's safer. It has a lower risk of bleeding. The fact that it has a lower risk of bleeding, so we say option A, which says that the radial vascular access may be useful to decrease access site complication, is right, because with this radial access, the complications are usually lesser. Complications like hematoma, even risk of infection at that site because of is lesser. Then also because of this location of that site where we can easily secure hemostasis by probably compression. In patients that have coagulopathy, you can easily just be on that site, apply pressure, and that will help you to secure hemostasis. So option B, the radial vascular access preferred in patients with coagulopathy. So option B is also correct. So option A, like I said, option A is correct. Option B is correct. Then for patients with morbid obesity, I also mentioned earlier that's correct. Um, then for patients with an elevated iron arrow, these are patients that will be at high risk of bleeding. So you also want to use the easier vascular access where hemostasis can be easily secured. So option D is also correct. Then even from the 2025 American Heart Association guideline, I think they propose that the radial vascular access is the best access to be used in patients that are to undergo coronary angiography and is widely accepted. Then I think I didn't really see anywhere where they compared its use in United States and Europe outside this book. But generally, they say the radial access is widely accepted as the preferred option for coronary angiography. So option E, then however, in this book, the answer there, they said there is femoral access that is commonly used in US, while in Europe, they use more of the radial access than the femoral access. So with that, option E is the wrong option here. So the radial vascular access is more frequently performed in the Europe than in United States. So 28, the correct answer is E for question 28. Then question 29. Which of the following conditions, which of the following conditions does not justify immediate coronary angiography and, if needed, revascularization? So I think this question is asking us probably the indications from understanding. I think they're trying to ask us for indication of primary PCI. In this just recent 2025 guideline, indications for PCI includes one, say a primary PCI, indication of primary PCI includes one, say in patients with ST segment elevation MI presenting less than 24 hours after symptom onset, primary PCI should be performed with a goal of first medical contacts to device activation of less than 90 minutes, meaning from when the patient comes, if patient presents less than 12 hours after onset of symptoms, from when a patient arrives at the hospital where that PCI capable hospital, the procedure should be done in less than 90 minutes, less than equal to 90 minutes within arrival at the hospital. Or if the patient arrives in a hospital that is not PCI capable, the procedure should be done in less than or equal to 120 minutes from the time of arrival at the
Hello, guys.
non-PCI.
Sorry to
Sorry?
interrupt. We have a stable internet. This is Eugene. Dr. Josie is on, so kindly let's unshare so that he can continue and finish. Sorry to
All
interrupt.
right,
Thank you very much.
all right, thank you, Dr. Eugene. Thank you, Shifa.
Okay, so I think I'm done with this. So if there are any questions, I'm happy to take it. Then I can move to the next one quickly. Any questions?
Sorry, sir. Please, I didn't get what you said about this duct-dependent lesion for pulmonary and systemic circulation. At least I think I know I can remember what you said about transmission of great arteries, where you said for these ones the oxygenated blood will tend to go more to the extremities than the head and neck, as opposed to PDA and PFO. For this duct-dependent lesion, I didn't really get what you said about it, sir.
Okay, so duct-dependent lesions are lesions, congenital heart defects that depend on the ductus arteriosus or PDA to maintain circulation either to the lungs or to the systemic circulation. So, for instance, if you have pulmonary atresia with a VSD, the only way you will survive is if you have a ductus arteriosus or a PDA, because if you have pulmonary atresia with a VSD, blood from the right ventricle will go across your VSD to the left ventricle, up the aorta, and the only way you would get some pulmonary circulation if you have a PDA that shunts the blood from the aorta into the pulmonary artery. So that would be a duct-dependent lesion for pulmonary circulation. On the other hand, if you have, let's say, severe coarctation of the aorta, it means that the coarctation which has occurred around the junction of the insertion of the PDA and the descending aorta would ensure blood flow just to the head and neck vessels. But because of the presence of a PDA, the blood is able to flow from the pulmonary arteries to the descending aorta to perfuse the lower limbs of the body. So in this case, you would have a duct-dependent lesion for systemic circulation. So that is what I meant by the duct-dependent lesion. So in this case, you have the persistence of fetal shunts that are helping the adult or the child to survive because they are assisting with circulation either to the lungs or to the rest of the body. I'm not sure if that clarifies the statements I made previously.
It's very clear, sir. Thank you, sir.
Yeah, thank you very much. Any other question before I move on? Okay. So maybe I can move on then. If there are any further questions, we can look at it later on. I don't know how much time do I have for the next presentation.
Hello, Dr. Dela, you can do up to 10 p.m. if you can.
Okay, all right. So what I'm going to do? Okay, all right. Thank you. So so the second half of the presentation is on the left-right heart shunt lesions. And I know we did, remind me, I think we did ASD and then VSD, but I can quickly do a recap of them and then we can delve into the last three lesions, if that's okay.
That's fine, sir.
Okay, all right. So, so we did talk about, this presentation was essentially on left to right heart shunt lesions. And I did give an outline. So I'll just move from there and then we can move. So we said the left right heart shunt lesions are either an atrial septal defect, an atrioventricular septal defect, a ventricular septal defect, an aortopulmonary window, or a patent ductus arteriosus. So these are the traditional left right heart shunt lesions. Number 4 is extremely rare, but we'll still talk about it. It's always important that in congenital heart defects, whether in pediatric or adult, that during the evaluations, the clinical features, chest X-ray, ECG, and echo must sing the same song. And what I mean is that there must be consistency in whatever findings that you find you make either on your examination, your chest X-ray, ECG, or echocardiography. None of them in itself is enough to accurately give you close to 100% certainty of diagnosis. So it's always good to go through that motion. So straight to the first one, atrial septal defects. So this is a left right shunt at the atrial level, and because of that, it tends to cause dilatation of the right atrium and the right ventricle with increased pulmonary blood flow. Now, the shunting of blood from the left atrium to the right atrium is dependent on the size of the atrial septal defect, the compliance of the ventricles, and then the differentiation between the pulmonary vascular resistance and the systemic vascular resistance. So if your pulmonary vascular resistance is more than your systemic vascular resistance, then it means that the pressure on the right side is more than on the left, and therefore that will limit the left-right heart shunt. But if the converse happens, then the systemic vascular resistance, if it's lower than that of your pulmonary vascular resistance, then you have more. If your pulmonary vascular resistance is less than your systemic vascular resistance, then you have more of the left-right heart shunt occurring. And then we said that over a period of time, the left-right heart shunt causes pulmonary overcirculation with remodeling of the pulmonary vasculature, leading to an increase in the pulmonary vascular resistance. And that is why, invariably, by the time you have ASD and you are into your sixth decade, you certainly will have symptoms of pulmonary hypertension, Eisenmenger syndrome, or some form of arrhythmia. So this is just an illustration from the American Heart Association that shows where the defect is, and we can appreciate the left-right heart shunt, red oxygenated blood mixing up with deoxygenated blood, and then all this blood ends up in the pulmonary artery and then the pulmonary vasculature. So there are different types of ASDs which we should know. The secundum ASD, which is around the mid portion of the septum in the area of the foraminal valley. Then we said that the primum ASD, which is close to the insertion of the AV valves, and it's part of the broader endocardial cushion defects, and it tends to be associated with a cleft in an anterior mitral valve leaflets. Then we talked about the sinus venosus ASDs, which can be either superior or inferior, the superior being at the point of, or the junction of the SVC with the right atrium, and the inferior sinus venosus, which is at the junction of the IVC and the right atrium. And we said that the sinus venosus ASD is associated with the total anomalous pulmonary venous connections or partial anomalous venous connection. And then finally, we talked about the coronary sinus ASDs, which are usually a connection between the coronary sinus, which is a structure, and the posterior aspect of the left atrium, and that connects into the left atrial chamber. And they tend to be associated with the persistent left SVC. So this illustrates what I've talked about: the superior sinus venosus ASD, the secundum ASD, the inferior sinus venosus ASD, the coronary sinus defect, okay, which we see over here. So that's the types. We did say that there are some genetic associations with ASDs which we must know about. The common ones being Holt-Oram syndrome, which is associated with limb abnormalities, as well as varying degrees of heart blocks. Okay, we said Holt-Oram is autosomal dominant, and it usually have an ASD, absent radii, and then you may have some arrhythmia. Then we said Ellis-Van-Creveld, which is also associated with skeletal dysplasia, and its inheritance is autosomal recessive. And then we talked about the NK2.5 gene defects, where you have familial ASD. So ASDs are run through families, and these family members tend to have AV block as well. Okay, so these are the common associations. So in effect, if you have any adult with an ASD, the family history is important. And then you need to do an ECG, looking out for not just the regular things we see on ECG for ASDs, but you must look out for heart blocks as well. And why should we be worried about ASDs? Because we are at risk of paradoxical embolisms and stroke, especially amongst adults. pulmonary hypertension, like I said, by the 6th decade, right-sided heart failure, atrial fibrillations or flutter, and then heart blocks. Okay. And typically, ASDs can go undiagnosed for many, many years. Okay, and then they may be either progressive, exercise intolerance, recurrent chest infections, or we may have on occasion incidental murmurs and abdominal heart sounds. Or there may be a family history and the patient will come to you just for some screening. Physical examination may be normal, but where you have right-sided overload, you have right-sided features, and then the characteristic fixed split of the second heart sound. In the case of Eisenmenger, you may have cyanosis and digital clubbing. Chest X-ray may also be normal, but you may have cardiomegaly. You may also have prominent pulmonary artery when the shunt is significant with pleuritic gland fields. Less commonly, you may have left atrial dilatation when you have a primum ASD that is associated with a cleft in the anterior mitral valve leaflet, which leads to severe mitral valve regurgitation. In that case, your left atrium may also be dilated. So these are what you expect typically from an ASD. You see the right atrial border, which is quite prominent here. And in a lateral view, you can see the left ventricular chamber, which is the most anterior chamber here, being so close to the sternum, suggestive of a right ventricular dilatation. On ECG, typically sinus rhythm, right axis deviation, first degree heart block, right atrial enlargement, right ventricular hypertrophy, and right bundle branch block. But when you have a coronary sinus rhythm, when you have a sinus venosus, you must look out for a coronary sinus rhythm. And I know you guys know about that. Inverted P waves before normal QRS complexes. If it's a primum ASD as part of the endocardial cushion defects, the axis will be a left axis deviation. You must also look out for
Hello, Dr. Agent. Please, can we go back to the MCQs whilst we wait? Okay, so Dr. Freno, please, let's continue whilst we...
Okay. All right. Thank you, Dr. Goodwin. So, on question number 29, right? Okay, for question 29, so which of the following conditions does not justify immediate coronary angiography and, if needed, revascularization? Like I mentioned earlier, this question is, I think they asking us recommendations for primary PCI. And like I mentioned earlier, the current, that's the 2025 American Heart Association, American College of Cardiology guideline, and recommendations for primary PCI includes one, in patients with SEMI presenting less than 12 hours after symptom onset, primary PCI should be performed with a goal of first medical contact to device activation of less than or equal to 90 minutes. So if the patient arrives, that's if the patient was taken to a PCI capable center, that's a center that has facilities to do PCI, in less than or equal to 90 minutes, the patient should have had the procedure done. If patient arrives in less than 12 hours from symptom onset. However, if the patient was taken to a center where that does not have facilities for PCI, the procedure should be done in less than or equal to 120 minutes from the first medical contact. From first medical contact, it is thought to improve survival. This is a class 1A recommendation. Then 1B, the second recommendation is that in patients with acute coronary syndrome and cardiogenic shock or hemodynamic instability, emergency revascularization of the vessel by PCI or CABG is indicated to improve survival, irrespective of time from symptom onset. So if a patient presents with symptoms of ACS with cardiogenic shock, or the patient has some level of hemodynamic instability, emergency revascularization of the corporate vessel by PCI or CABG is indicated to improve survival, irrespective of the time from symptom onset. So whether a patient arrives 24 hours after onset of symptom, patient presents with symptoms in keeping with ACS, with cardiogenic shock and hemodynamic instability, a PCI or CABG can be done for a patient. That's a class 1B recommendation. Then also, say in patients with S segment elevation myocardial infarction who present 12 to 24 hours after symptom onset, primary PCI is advised to improve clinical outcomes. So even if the patient presents later than 24 hours after onset of symptom, the primary PCI is said to be reasonable to improve clinical outcomes. Then the the fourth recommendation is that if a patient presents with SEMI greater than 24 hours after symptom onset, and patient has symptoms suggestive of ongoing ischemia or life-threatening arrhythmia, PCI is reasonable to improve clinical outcome. That's class 2A recommendation. Then it also said that in patients who are stable with S-segment elevation MI who have a totally occluded infarct-related artery greater than 24 hours after symptom onset, and are without evidence of ongoing ischemia, acute severe heart failure, life-threatening arrhythmia, primary PCI should not be performed
Hello, Godwin.
for that.
Can you hear me? Sorry to interrupt. So after this question, Dr. Dela is back on. Then we can go back to him.
Okay, sure.
Okay.
Uh,
All right. Thank you, Chief Eugene. So we'll go back to the questions now. So which of the following conditions does not satisfy immediate coronary angiography, and if needed, revascularization? So for option A, say if 7-year-old man presenting with typical chest pain lasting 60 minutes up to emergency department arrival, as cardiologist on call, you are called in immediately, and when you see the patient, his pain has virtually disappeared, while ECG shows 2 millimeter S segment elevation in the inferior leads. So for this patient, the patient arrives in the clinic within less than that window period talked about, less than 12 hours. So the patient arrived in 60 minutes to the emergency, and the patient initially had chest pain, which has however disappeared. However, ECG is suggestive that the patient actually had an inferior MI. So for this patient, the patient will require emergency coronary angio and possible stent insertion. So option A is correct. So option A, for that patient will require a primary PCI. To the fact that the patient arrived earlier, the patient had chest pain, arrived in less than 60 minutes from the onset of symptom, and ECG shows features suggestive of ST segment elevation MI. So that patient will require benefit from coronary angiography and possibly a PCI, coronary revascularization. Then option B, a 60-year-old diabetic man known for previous coronary disease presenting with not better defined chest discomfort lasting for 10 hours and currently decreasing intensity with pulmonary edema and 30 millimeter ST segment elevation in the anterior leads on ECG in the absence of Q waves. So for this man, a 60-year-old man, diabetic, has had coronary artery disease before, and presenting with chest pain that lasted for 10 hours. And even though the pains of decreased intensity and patient also has pulmonary edema, we know that for diabetics, sometimes they will present with silent MI, and patient has ECG finding suggestive of an ST segment elevation. So patient B, as for option B, this 60-year-old man will also require immediate coronary angiography and possible revascularization. Then option C, a 65-year-old man known for coronary artery disease, complaining of progressive shortness of breath since 1 week. At admission, no ongoing chest pain with stable hemodynamic status, but by basilar rails at auscultation, the ECG reviewed ST segment elevation as well as Q waves in the anterior leads. Now, I mentioned earlier that patients are part of the recommendations for this 2025 guideline. They said in patients who are stable with ST segment elevation MI that have a totally occluded infarct, as typified by the probably presence of S segment elevation as well as Q waves in the anterior leads. Patients with totally occluded infarct-related artery greater than 24 hours. This patient presented at I think 1 week following onset of symptoms. So if they present with after 24 hours after symptom onset, and they don't have evidence of ongoing ischemia, as in this patient, they have acute symptoms or of acute heart failure or arrhythmia, say PCI should not be performed due to lack of benefit. This is a class 1C. This is a class 1C recommendation. So for this C, option C, the 5-year-old man known for coronary artery disease complaining of progressive shortness of breath since 1 week. So the patient presented 1 week after experiencing shortness of breath. And when he presented, there was no chest pain. He's stable hemodynamically. He has raised on auscultation. Then the ECG reviewed S segment elevation as well as Q waves in the arterial leads. All this had happened probably about 1 week before time. So this patient will not benefit from coronary angio and revascularization. So this is likely the right option. For option D, a 70-year-old man presenting to the preceding 20 hours. Upon your arrival, he has mild chest pain and on ECG, 2 meter ST elevation in the lateral leads. You know, I mentioned earlier that even in patients presenting with STEMI, these patients are presented within 20 hours. Now, I mentioned as part of the recommendation of primary PCI that patient presenting with STEMI within 12 to 24 hours after symptom onset. And it's a class 2 recommendation that the patient doing angiography and possibly inserting a stent, is thought to improve clinical outcomes. So for this 70-year-old man presenting to the emergency department with on and off chest pain in preceding 20 hours, this patient will require coronary angio and possibly vascularization. Then option E, a 68-year-old diabetic man presenting to the emergency department with chest pain lasting 4 hours, with hypotension, tachycardia, ECG showing 3 mm segment elevation in the anterior and lateral leads. For this man, is very clear. The patient is 68, is elderly, is diabetic, having typical symptoms, typical angina symptoms lasting for 4 hours. And patient is hemodynamically unstable, certified by the hypotension and tachycardia the patient has. ECG is also suggestive. So this patient will benefit from immediate coronary angio and revascularization. So I think Chief Eugene asked that we'll go back to our presentation after this question. If there are contributions or queries before we go back, I think we are welcome at this point.
Thank you very much, Dr. Eno.
Thank you, Dr. Gordon.
Dr. Eugene.
Yeah, Gordon.
Okay, thank you.
Yeah, he'll be sharing the slides soon.
Hello once again. I'm not sure what's happening today, but hopefully we'll get to the end somehow. So apologies again. I think I've dealt with this slide already, the ECG changes in ASD. And we've spoken about the sinus, coronary sinus rhythm, left axis deviation, and atrial tachyarrhythmias. Okay, let's do this. Okay. So the role of echo is to define the defect, the size, and the hemodynamic state, and then also define associated lesions. So this would be a typical view of various types of ASD. So this will be a secondum ASD and a primum ASD in the same patient. And so if you put it on color flow, you can appreciate the left to right heart shunt across the secondum as well as the premium, and then the regurgitant flow as observed with the cleft in the anterior mitral valve leaflet. Okay, then from there proceed to cardiac catheterization, where you do some hemodynamic studies and then also assess the left ventricular and diastolic pressures and the coronary artery in older patient. Because like I did indicate previously, if you are in older patients, a small ASD may actually serve as a pop-off for the left ventricular and diastolic dysfunction. So in that case, when you go and close the defect with the device, you need to recheck the left ventricular and diastolic pressure to see if it's gone up. If it's gone up, then it means that you are better off leaving that small ASD and not closing it. So definitive treatment is based on evidence of right heart volume overload and not the symptoms. Because invariably, if they are not symptomatic at a younger age, they'll certainly become symptomatic at an older age. Some ASDs may close in childhood, but ASDs in adults will not close. And the surgical closure occurs with the repair of other associated lesions. So these are typically the kind of device that you use in an ASD closure where the pointer is. Okay, so this is a typical ASD device occluder. Typically in the cath lab, we will do what we call balloon sizing of the ASD. Because the ASD has rims that may be flimsy, you need to be sure that the rims are adequate enough to hold a device. So this is a balloon catheter across an ASD, and you can appreciate the waist that has been formed. So the waist is measured here to confirm the exact size of the ASD, and that will inform the size of the device that is used. And then subsequently, a device is inserted in place to close the ASD, which you can see over here. Okay, and this is on angio. And then on chest X-ray, you can also appreciate the ASD device right here from the right atrial border around the area of the margins of the spine as well, which is where you typically use as a landmark to confirm that your device is in the right place. So post-ASD closure has some long-term problems that we need to pay attention to. So surgical closure of ASD still leaves you at a lifelong risk of atrial fibrillation and flutter. And then within the first 6 months, you can also be at risk of infective endocarditis as well as pericardial effusion. Where the ASD is closed with the device, the typical complications arising from a device insertion are also present, such as embolization. But also importantly for ASD is still the risk of arrhythmias, thrombus formation, device erosion into the surrounding structures, especially the aorta, cardiac perforation, and residual lesions. Medical treatment always has a role in ASD in the management of the atrial arrhythmias and then pulmonary hypertension as well. We also spoke about some controversies that we should also bear in mind. And some of these controversies include the fact that should all ASDs be closed irrespective of the size? Because in the past, some people thought you can leave very small ASDs, but because of the risk of paradoxical embolisms, and also for people who work in high altitudes, okay, or in who do deep sea diving, no matter how small the ASD is, it's always important that those ASDs are closed. And then also the question of which ASDs should be closed surgically or with a device is also an area of controversy. Currently, in some European centers, all sizes of ASDs are closed with the device, but that depends on also the skill of the interventionist. So we quickly go to ventricular septal defects. we said that they constitute about 20 to 40% of all congenital heart defects. They also a left-right heart shunt lesion, but this time at the ventricular level. And unlike the ASDs, this is associated with the left atrium, left ventricular dilatation with increased pulmonary blood flow. So you take note of the differences already. ASD primarily causes a right-sided dilatation, and VSD causes a left-sided dilatation, even though they are both left to right heart shunt lesions. The shunt depends on the size of the defect and as well as the difference between the pulmonary vascular resistance and the systemic vascular resistance. And then just like the ASDs, there's remodeling of the pulmonary vasculature leading to increasing pulmonary vascular resistance. Pulmonary hypertension, Eisenmenger, may ensue if the defect is big and not repaired. So typically, an illustrated image from the American Heart Association, we can appreciate what is happening here. And even though it's a left to right heart shunt lesion, in this case, the blood does not stay within the right ventricle as much. It crosses over straight into the pulmonary artery, into the pulmonary vasculature, and then it returns quickly through the pulmonary veins into the left atrium and back into the left ventricle, which accounts for the left-sided dilatation. Just like ASD, there are various types of it. You have the inlet VSD, which is associated with endocardial Cushing defects. And so you typically find that they are just around the area of insertion, just below the area of insertion of the tricuspid valve. Then there are the muscular VSDs, which are within the muscular septum, and they tend to occur in multiples and have been tagged as the Swiss cheese VSDs. Then there's the perimembranous ones, which are usually associated with subaortic membranes that cause subaortic stenosis. So these typically, if they are not addressed, are the ones that may appear in adulthood where the discrete subaortic membrane causes a subvalvular stenosis, which subsequently destroys the aortic valve leaflet because of the jet arising from the left ventricular alveolar tract obstruction. And so usually during the surgical closure of these VSDs, it's important that the subaortic membrane is also excised because of the natural history of it. Then we have the outlet or doubly committed or subarterial. You may see these words used based on what school of thoughts, whether it's Van Prague or Anderson. And they are typically associated with chondrotruncal abnormalities, so like tetralogy of Fallot, truncus arteriosus, and so on and so forth. And they typically occur with severe aortic regurgitations. So just like ASDs, VSDs are also associated with genetic disorders. And the commonest ones that we find in VSDs are the diGeorge, that's the 21q microdeletion, then trisomies 21, 18, and 16, Noonans, and then the infants of diabetic mothers. So these are the ones that typically are associated with the VSD. The history of VSD, they can also be asymptomatic if they are small, or if they are moderate to large, they can come with features of heart failure, which are age dependent. So if it's in an adolescent or younger child, they'll be failing to grow. In older ones, you have your typical autopnea, paroxysmal nocturnal dyspnea, and so on. They may also appear already in pulmonary hypertension if the defect is not repaired. And I spoke about the ironic initial improvement where in adolescents, they may have heart failure as they approach adulthood, where they are becoming pulmonary hypertensive. They may go through a period where they're actually okay because the symptoms of heart failure disappear. But then subsequently, the symptoms of pulmonary hypertension take over and they begin to deteriorate. Physical examination dependent on the size of the defect, but typically they are well saturated. They may show signs of precordial activity with displaced apex if they're in heart failure. They typically will have a holosystolic murmur, the left lower sternal edge, or an ejection systolic murmur if the defect is so big. In that case, the murmur was not arising from the VSD, but rather from the increased pulmonary blood flow. They may also have a mid-diastolic murmur, which is also functional, and that is because of the sheer volume of blood returning from the pulmonary veins into the left atrium. And that's what causes a diastolic murmur. If they appear with pulmonary hypertension, then they'll have the typical pulmonary hypertension and Semega features such as the cyanosis, RV hips, epigastric pulsation, loud P2, soft murmurs, or the disappearance of previously existing murmurs. Chest X-ray finding also depend on the size of the VSD. So you may have a normal cardiac size with normal cardiac silhouette, or you may have a cardiomegaly with left-sided dilatation. So you may have like LA dilatation on X-ray, which will show us either the spleen of the carina or the enlargement of the left, the prominence of the left cardiac borders around the left atrial appendage. And then you may have plethoric lung fields as well. But as the BSD gets bigger with increasing pulmonary vascular resistance, then in addition, you may have pulmonary artery dilatation with pruning of the pulmonary artery vessels. And then in inlet VSDs, we have the characteristic gooseneck appearance, which I'll show in a subsequent presentation. So this is what we talked about: increased pulmonary vascular markings, spleen of the carina. Okay, it's suggestive of left atrial dilatation. Okay. And you can see in a very large defect, the sheer amount of increased vasculature around the hilar region. And if you look carefully, you can see cephalization of the pulmonary vein, suggestive also of right heart failure. And then you can see the fullness of the pulmonary artery on this side, suggestive of dilated pulmonary arteries. ECG, the findings may be normal. In the inlet type, AVSD type, you would have a left axis deviation. And when there's evidence of pulmonary hypertension, you may have a right axis deviation with right ventricular hypertrophy in a right bundle branch block. Okay, so the ECG is able to give you an idea of what's happening with your VSD. Echocardiography defines the location, the size, and hemodynamic effect of the VSD, and various views help with various types of the defects. So we talked about the PMVSD, which you are better seen in the subcostal or parasternal long and short axis. The muscular VSDs, which you typically will see in the apical 4 or parasternal short axis. The inlet in the apical 4, and then the outlet in the subcostal, parasternal, long and short axis. So the PMVSD and the outlet VSDs share similar views. Okay, and then the muscular and the inlet tend to be typically more obvious in the apical 4. So that is a simple way of remembering it. So let's see if this video will play here. Okay, so this will be a typical PM VSD here. Okay, but then it has a bit of an outlet component as well. Okay. Then we can see in the parasternal short axis where we see a defect here that spans from about 9 o'clock to about 11 o'clock. So this is typically like a PMVSD with some outlet extension as well. Okay. Then we see a parasternal long axis view, and we can see this VSD is in such close proximity with the aortic valves. So these are the kind of VSD where the coronary cusp here can prolapse through the VSD and end up giving you aortic regurgitation. Okay. So you can see this coronary cusp here can just get sucked into the VSD, okay, and then give you AR. Then we can see a typical muscular VSD, mid-muscular VSD here. These ones can easily go unnoticed, okay? But you always need to pay attention to them. And one of the things is that once you see one VSD, you must look for other VSDs, okay? You don't assume that all you've seen is one. Okay, so another VSD, a PMVSD, in an apical or apical 5 chamber view. So in the cath lab with VSD, you can also do hemodynamic studies especially in, adult, where you want to establish that one, the shunt is significant and that even if you have features of pulmonary hypertension, it is reversible before you go and close it. You also have to define other lesions such as tetralogy of Fallot and interrupted aortic arch. And then you can also assess the VSD and decide whether this is a VSD that can be closed with a device. Okay, the other investigations that we can do for VSDs. The treatment options, you have watchful waiting. Some VSDs can close spontaneously, especially the muscular ones. Medical treatment, managing the heart failure. Surgical treatment, using patches to close the defect, or we can use a device closure. So once again, this will be a typical VSD device occluder. Okay, we already showed the ASD, so this is a VSD one. And so this is how it will happen. It will show typically after you have put it in place. Okay, so you can see the device here, hyperechoic lesion there within. So this was one that was used to close a muscular VSD. And then if you look carefully where this is here, you can see the VSD device on this side. If you remember, the ASD device was shown typically here. So this is a patient who had a previous surgical closure of the VSD. So you can see the stenotomy wires there, but then there was a residual VSD and which was subsequently closed with the device. So post VSD closure, once again, there's always a lifelong risk of complete heart block. Okay, because of the presence of the bundle branches along the septum. Okay, and then there's also a higher risk of residual defects, which are indicated in the previous patient who needed eventually to have a device closure after bypass surgery. And then for the VSDs that are perimembranous, typically the tricuspid valve leaflet, the septal leaflet attempts to close the defect. So after you've actually retracted to close the defect, you may end up having some tricuspid regurgitation. With the device closures, the typical problems, embolization, thrombus formation, perforation, but there also you have a lifelong risk of complete heart block. And this must be borne in mind during the follow-up visits. Okay. We currently have, I think, an 18-year-old who had a VSD repair done about 8 years ago and now has come with complete heart block. So these are real issues that we need to pay attention to. So atrioventricular septal defect, as the word indicates, there's a defect both in the atrium and then in the ventricles as well. But in addition, you have deficiencies or one or both AV valves. So if you remember when I talked about the primum ASD, I said that they are associated with anterior mitral cleft in the anterior mitral valve leaflets. The same for inlet VSDs as well. Okay, so you are typically dealing with 3 lesions. They were previously known as AV canal defects or endocardial cushion defects. They are about 4 to 5% of all congenital heart defects, and they are common in patients with Down syndrome. So if you have an adult with Down syndrome, you hear in members, one of the defects to worry about is the atrioventricular septal defects. Okay, so an illustration of it, a defect in both the atrium and then the ventricular septal wall. Because you're essentially dealing with 2 big shunts and valve regurgitations, AVSDs are typically associated with heart failure at a very early age and then early onset of pulmonary hypertension. And I'm sure you can appreciate what's happening. You have a shunt at the atrial level, at the ventricular level, and all these regurgitations either on the left or the right. So typically with the ventricular, the ASD components, you have dilatation of the right atrium, right ventricle, and the pulmonary artery. And then with the mitral valve insufficiency, you have dilatation of the left atrium and the left ventricle as well. So all the chambers are dilated. The shunts cause the right side to be dilated, the AV valve, especially the left AV valve, cause the left side to be dilated. And so you have an accelerated journey to a pulmonary vascular obstructive disease, which is why for such patients, they need to be operated at worst by the time they're about 9 months. So if you see an adult with AVSD, most likely they have irreversible pulmonary hypertension. If you decide to go and close it, you need to do pulmonary hypertensive studies to be 100% sure that they are operable. Okay. Just like ASDs and VSDs, there are also types of AVSDs. We have the partial, the transitional, intermediate, and the complete types. Okay, so let's see how they look like. This is an illustration from an article I read some time ago. So this is a complete one. In the complete one, there's one AV valve. There's an atrial communication and a ventricular communication. So just one valve. In the intermediate one, you have two valves, but you still have a large atrial communication and a large ventricular communication. Then there's a transitional one. You have two valves, but the shunt is predominantly on the atrial level, but there's a tiny ventricular level. So that's what you call transitional. Then finally, you have the premium one, which I spoke about earlier on, or the partial, where the defect is primarily a premium ASD. So these are typically the way that they are classified, and they all have implications as far as management and symptoms and management are concerned. So you can actually appreciate the fact that these ones will have severe symptoms, okay, and then it gets better and better as you get to the partial ASD type. Okay. Now, in addition to that classification, the complete ones are further classified as balanced or unbalanced AVSs, and that is based on the relatively size of the ventricles. Okay, so you can have a complete one where the ventricles are of the same size, so they are balanced, or when they are unbalanced, and you can see from here that the right ventricle is larger than the left ventricle. So these are an unbalanced ventricle with an RV dominant ventricle. And these are important in the management of the patients, because if your ventricles are unbalanced, you cannot just go and close the VSC, because you'll be left with a relatively small ventricle that cannot cope with systemic circulation, and a big right ventricle, which, I mean, it hasn't got the core support it usually depends on from the left ventricle. So essentially, this is what I'm talking about. This is a complete AVSD with a single AV valve, and the ventricles are balanced. But here you can see the ventricles are unbalanced. The right is dominant here, the left is dominant here. Most of the time you may have right dominant ones. So let's see if this video plays. Okay, so this is not is a still video. So on echo, this is what you typically will see: right atrium, left atrium, atrial defect, ventricular defect, and then all of this is the right ventricle, and what is here is the left ventricle. So this is a complete AVSD with unbalanced ventricle and the right ventricular dominant ventricle. So history, like I said, most of them occur in patients with Down syndrome, and they will present with features of heart failure and pulmonary hypertension very early on than all the previous defects. Physical examination, the same, dysmorphic fasces in Down syndrome. The saturations may be normal to low because of the amount of streaming of blood. Okay, you have blood mixing up and below. So they actually sometimes behave like common mixers where you have all the oxygenated and deoxygenated blood mixing up. But of note is that because the atrial and ventricular defects are so large, you don't tend to hear murmurs arising from them. The murmur is typically from the AV valve regurgitation of either the left or the right atrioventricular atrioventricular valve. So chest X-ray have severe, features of pulmonary congestions, proning, and the gooseneck deformities as well. Okay, so this would be a typical one where you have all the chambers dilated. Okay. ECG, superior axis deviation or left axis deviation. I know in adult cardiology, you tend to use left axis deviation. In pediatric cardiology, we would say superior axis deviation, but it's about the same thing. Okay, and then in addition, they may have varying degrees of heart block. Echo will define the type, the extent of the AV valve regurgitation, the ventricular size to determine whether they are balanced or unbalanced, and then if there are any associated lesions. AVSs typically tend to go with tetralogy of Fallot. So that's one thing to look out for when you have diagnosed AVST. So this will be some images. So this is a typical one. You can see this is a complete AVSD, a single AV valve with a large atrial defect, large ventricular defect, and then an unbalanced ventricle. So this is what's left of the right ventricle, and this is the left ventricle. So this would typically be called complete AVSD, unbalanced ventricle with a left ventricular dominance. So let's look at this second one here. So this is also a complete AVSD because you can see the single AV valve, okay? But then you can see that the ventricles here look balanced. But what I've noticed is that when you look on the color Doppler, you can see that both the AV valve is regurgitant. Okay. So this is what sometimes you would call, like, if you go back to the classification, in this case, if you look carefully, they're actually two distinct AV valves. And you can see that from the two jets that are here. So if you go back to the classification we had, that would be like an intermediate. Okay, let's see. So this will be an intermediate form here, where you have two AV valves. Okay. All right. So when doing in the cath lab, the main thing is pulmonary hypertension studies, especially if you have an adult with an AVSD. I think I don't know if Eugene, you remember last 2 weeks we had I think a 24-year-old from Sierra Leone who came with atrial fibrillation, and then in addition had AVSD with predominantly a permanent ASD. Okay. Eugene, you're on. Yeah. So that's one of the things that you do within the cath lab, assessing the pulmonary pressures before you go and try and close. And then they also typically tend to have left ventricular outflow tract obstruction. In AVSD, the aortomitral continuity that you typically have is distorted. So rather you have the aortic valve a little bit more superior to the insertion of the mitral valve. So you end up having a very long, narrow left ventricular outflow tract, which tends to be obstructive. So every adult with AVSD, you must look out for left ventricular outflow tract obstruction. All right. Okay. And then, like I did indicate previously, you must look out for tetralogy of Fallot as a common comorbidity with AVSD. So this is what you typically will find, like I said, on angiography with AVSD, where you have this long left ventricular outflow tract, and it's because of, like I said, the superior insertion of the aortic valve instead of the common aortomitral continuity that you get. And so that gives what you talk about as the gooseneck appearance in AVSDs. Management, medical management with heart failure and pulmonary hypertension. Surgical management is tricky. I mean, it's one of those defects that give surgeons a nightmare because, like I said, you have an atrial defect, ventricular defect, and valve, which also need attention. So if you don't get it right, you end up with a lot of residual lesions. Okay. Post-repair, there's a lifetime risk of complete heart block, like with the VSDs. There's a lifetime risk of reoperations because of residual defects and the valve abnormalities associated with it, and also because of the left ventricular outflow tract obstruction I spoke about. even after you have repaired the defects, there's still some selected patients who still go on to have pulmonary hypertension. So what are some of the controversies with AVSD from the clinical point of view? The timing of the surgery. Okay, even though they tend to have pulmonary hypertension early, there are some school of thought that still manage it medically, allow some time before you go and close it. Some people think because of the pulmonary hypertension, close it as soon as you diagnose it. Okay. Then there's the issue of whether you should close all the defects in one surgical session or you should do it in a staged form. And the single stage people feel that close everything, manage the rest of it medically. The multi-stage feel that because of the risk of pulmonary hypertension, take away one lesion at a time so that the pulmonary pressures can have time to completely fall before you close the final defect. Okay. And so it's just worth taking note of these things. I'll pause here before I go to the last two lesions. If there are any questions, we can take them.
Guys, let's be forthcoming with our questions. It's a bit late for Dr. Josie, but he's ready to help out. So if there are no questions, then you can go ahead to do the next presentation, the PD. Thank you. It's either the presentation has been excellent or Dr. Josie has been able to confuse all of you. Gordon, are we still on? Can we be heard? Hello? Are we talking?
Yes, sir. We can hear you, Dr. Eugene.
Okay, all right. So he will continue on.
Let's continue, please.
Right.
Sorry, for the VSD, the one that you showed on parasternal lung axis, where you
Yes.
talked about the possible prolapse of the cuff into the VSD. That's more of that is sub-aortic or the inlet type.
Okay, so the location on this view, because of the close proximity to the aortic valve, is more of a subaortic, perimembranous subaortic VSD.
Okay.
But you also have some inlet VSDs that can appear that way on parasternal lung axis as well.
Okay.
Those ones you will
So how
see
do
a
we
lot
know? How do we know which is which? So how do we know which is which, whether it's on the subaortic or the
A very good
inlet?
question. Which you have to go to the parasternal short axis, because on the parasternal short axis, then you can be able to tell the differences as well. Because on the parasternal short axis, if the defect is around 9 o'clock, then it's about if between 6 o'clock and 9 o'clock will be like perimembranous, then 9 o'clock going to like 12 o'clock will be the subaortic or doubly committed VSD. So it's a very good question. One view is always not enough to classify. You just need to look at it in other views as well, and then you can clinch the exact type.
All right. Thank you, sir.
You're welcome. Okay, so I'll move on to the next one. Let's see. So the patent ductus arteriosus. So we're talking about isolated forms. Like I mentioned earlier on, PDAs can be associated with a lot of lesions. But for the purposes of our discussion and the left-right hand shunt, we are talking essentially about the isolated ones. They are common in preterms. Okay, and even preterms who grow into adulthood will still more often than not maintain their PDAs. Okay, it occurs because of the failure of the ductus. Oh, sorry, it's ductus arteriosus, not ductus venosus, to close after 72 hours to up to about 3 months. Now, what this statement means is that usually we expect the ductus arteriosus to close a few after about 15 hours after birth. But at that, if it doesn't close, we still won't call it a patent ductus arteriosus until after 72 hours. Then we can call it a PDA. And most PDAs will close by 3 months. So if after 3 months they do not close, then they're not likely to close. And if you don't do anything about it, they'll persist into adulthood. So that's essentially what that statement means. Okay. Okay, let's do this. And just like with VSD, it's associated with the left atrium and left ventricular dilatation with significant pulmonary valve dilatation and pulmonary artery dilatation. The shunt depends on, once again, the same thing, systemic vascular resistance and pulmonary vascular resistance. But in addition to the size of the lumen and the length of the lumen. So this is an illustration from the American Heart Association. Okay, you can appreciate the connection between the aorta and then the pulmonary arteries. And because of the proximity of the pulmonary artery to the high systemic flow and pressure, you have a significant dilatation of the pulmonary valve, pulmonary artery, and the branch pulmonary arteries. Okay. And that is how sometimes you can tell the difference between the VSD appearance and the PDA appearance as far as chambers are concerned. The pulmonary artery is a bit more dilated in PDAs than you find in VSDs. The fetal duct is a bit more different from the adult duct. The fetal duct is maintained by relative hypoxemia, like I said previously, the prostaglandins, and then the fact that the walls of the fetal duct are immature, so they're able to also respond to oxygenation. I've talked about this already, so I'll leave it. So for our purposes, and from an embryology point of view, ductus arteriosus is kept open by hypoxemia, prostaglandin, nitric oxide, a high PVR, and medications that are synthetic prostaglandin or prostin, which is why when you have duct-dependent lesions, we tend to give them prostin as the first line of management. The things that close the ductus arteriosus are high oxygen, increased prostaglandin metabolism in the lungs, and the medication starts as paracetamol and ibuprofen, which is why when you have a large isolated duct in the neonatal period, you can attempt to close it with paracetamol or ibuprofen or both. Broadly speaking, the PDAs are usually conical in shape, broad on the aortic side, and tapers in the pulmonary end. But there's an angiographic classification called Kachenko classification, which tells us that there are different types of ducts. And it's important in the cath lab because the different types of ducts will determine what kind of devices that you use. So in the type A, you can see the conical appearance. Type B is a window type. Okay. Type C is a tubular. And then D is a circular type. E is a very elongated duct. And then F is a fetal type. So typically, A is what you will close in the cath lab. B, you may consider closing, but with devices that have a lot of hinges on either ends. By the time you get to about C, these are the ones that can be so big that they may have to be closed surgically instead. Okay, so it's good to have an idea of this classification for an interventional point of view. I think last 2 weeks when we had a cardiac cath project, we closed a PDA of a 20-something-year-old, yeah, maybe closer to 28-year-old, who had a conical PDA, which we closed with an ampular device occluder. So these are real things that you encounter in the clinical setting. So PDA are commonly associated with congenital rubella syndrome, fetal alcohol syndrome, maternal amphetamine, maternal phenytoin, and then in preterms. So from an adult point of view, fetal alcohol syndrome, so mothers who are drinking alcohol into pregnancy are likely to have children who have PDAs. The mothers who are on amphetamine or phenytoin for seizure disorders are prone to have babies with patent ductus arteriosus. So like I've said previously with the other ones, some PDAs can go asymptomatic if they are small, and in actual fact, they can be actually silent as well. Then they may present in heart failure if they are big enough, or their first presentation because of an infective endocarditis, or they may present with pulmonary hypertension, Eisenmenger's. The physical examination features of heart failure, but I've noticed that they tend to have bounding pulses, and I'm sure you can understand why, because of the pulmonary runoff from during systole. Okay, and then because of that, they end up with wide pulse pressures. And then the murmur of PDAs can vary. So the typical continuous machinery murmur is not always present. When they begin to have pulmonary hypertension, they lose the diastolic component of the continuous murmur and end up with an ejection systolic murmur. And like I said, sometimes the ducts can be so small that you don't hear when you auscultate, and that's what we call the silent ducts. You see them on echo, but you don't hear them when you auscultate. So typical complications: heart failure, infective endocarditis, pulmonary hypertension. X-rays like the previous ones, depending on the size, but like I indicated, one of the key things about PDAs is the prominence of the pulmonary artery. Okay, the prominence of the pulmonary artery is very typical of PDAs. Okay, and then on angiography, this is how they appear, like the descending aorta, the duct connecting to a pulmonary artery. ECGs can be normal. You can have you can have right pulmonary repaired, and you end up with pulmonary hypertension. So this would be two typical views for PDAs. So the first one here, okay, let's see. Okay, this is your typical ductal view for a PDA. So this is like suprasternal view, and then you turn the knob, you angulate the beam towards the left shoulder. So what you end up with is the right pulmonary artery, the left, move the right, the left, the PDA here, which is flowing here, and then you have the descending aorta on this side. Okay. Okay. So this is a very large PDA in the suprasternal or the ductal view, as we call it. Then in the parasternal short axis view as well, you can appreciate the PDA. So the short axis, you can see the aorta, the aortic valve at the center, the right ventricular flow tract, the pulmonary valve, and the pulmonary artery, which is dilated, right pulmonary artery, the left pulmonary artery, and then the duct is on the extreme. So it's like what they call a dinner fork, like 3 limbs. Okay, I'll pause it here. 1, 2, and then 3. Right pulmonary artery, left pulmonary artery, and then your PDA. And then you can see the left to right shunt flow on the other view. In the cath lab, we profile the duct, do hemodynamic studies, define other lesions, and then you can close the defect. So I already showed you the image, the B image, which is an angiography, and the aortogram. Okay, this is a lateral view aortogram, and then we can see the descending aorta, the ampulla of the duct, which narrows down to connect to the pulmonary artery. Okay, so treatment, watchful waiting, medical closure with paracetamol or brufen, like I said earlier on, heart failure, pulmonary hypertension. It can be surgically ligated or you can do device closure. So these are some of the devices that we've typically used for closing. The adult we closed last 2 weeks, we use ADO1, which is the number 2 here. Okay. The calls were the earliest one, but they are being used less and less because they tend to embolize easily. Okay. Yes. So this is how it will look like on an illustration with the device in place, the ADO2. On X-ray here, after we've implanted the device, you can see the prominent pulmonary artery here, and then you can see the device on this side as well. That's how the device will look after it's been planted on X-ray. Post-repair, because of the proximity of the recurrent laryngeal nerve to the ductus arteriosus, it can be injured when the repair is done. So that's something we look out for, as well as the phrenic nerve in the thoracic duct. With the device, typical problems, embolization, thrombus, perforation, residual shunts. What are some of the controversies with PDAs, even in adults? Should all PDAs be closed? I talk about the silent duct. So we've had a number of adults who have come and for other, maybe they're coming for LV function assessment and then they have a duct, but you cannot hear it. Should you close those ducts? Okay. Uh, which ducts should be closed at what time? Which one should be closed with medical? Which one should you watch and wait? So the last one, your pulmonary window, is very rare. It's almost like a PDA, it's just that the connection is not at the branch from the aorta to the branch PA, as you typically have with the normal PDA, but the connection is between the aorta and the main pulmonary artery. It clinically presents like a PDA, but as you can see, because of the sheer volume and pressure in close proximity with the pulmonary artery, they tend to be pulmonary hypertensive also early. There are typically 3 types. Anytime you see an AP window, you must look out for other conotruncal abnormality. And management is strictly surgical. You don't try to close them with any devices. So this is an illustration of the 3 types. So the first type is where the connection is just after the semilunar valves to the bifurcation of the pulmonary artery. Then the second type is from the aorta and at the point of the bifurcation of the pulmonary artery. And the last one is between the pulmonary artery, the right pulmonary artery, and then the aorta. So 3 types of AP windows. So I'll show you how it looks like on echo. So you can see here, this is a parasternal short axis view. Your RVOT here, your main pulmonary artery, which bifurcates here. And then you can see this huge effect over there. Okay. So typically, if this was on the opposite side, it would be a VST. But on this side, it is an AP window. Okay, so I'll play it again. And this is a child that we have. I think this child is about 7 years. Okay, so he will need surgery. Okay. I took these images off my system today. Okay. All right. So that's the last image for the road. If you have any questions, I will take it.
Want to say a very big thank you to Dr. Deladosi for spending the whole day in the hospital, literally. We are still seated in the hospital to get this presentation done, and we are grateful for him doing this for us. And so please, let's get our questions coming in. If there are no questions, then we can let Dr. Josie sign off so that he can go. So, Gordon, any questions, any clarification?
For my side, I'm okay for now, but let me look at the chat box. I'm not seeing any questions in the chat box. So,
Hello, sir. Dr. Gordon, yeah, I have the questions.
okay, thank you. Go ahead.
Okay, thank you for your presentation, sir. And I really appreciate you, sir. Sir, for the, we talked about for management of PDA, and during the maybe early days of life, we talked about use of ibuprofen, which is an NSAID, then paracetamol. For during probably third trimester, will it be right or correct to say that NSAIDs, due to the fact that they block synthesis of prostaglandins, which ought to help maintain the patency of that PDA, can it cause premature closure of PDA in utero? I know commonly in pregnancy and the gynecology test, when the patient complains of pains and all that, they tend to be liberal with the use of paracetamol. If NSAID does it with paracetamol that they usually use, can it also cause it, as in towards the end of the third trimester?
Okay. Yes, very, very good question. So the answer to the first question is that yes, if you do give the NSAIDs in the third trimester, you risk closing the ducts. And we've talked about the role of prostaglandins, and so it's real. What is not proven is whether paracetamol does the same thing to the fetal duct. So that is not fully established, which is why, people still go ahead and give it. But what we know for a fact is that in the neonatal period, if you do give the paracetamol, it causes closure of the duct.
All right, thank you, sir.
You're welcome.
Okay, in the absence of further questions, I think want to appreciate Dr. JC and we'll allow him to sign out now. Hopefully, based on his schedule, if tomorrow is feasible, we'll communicate to the coordinators. Thank you very much.
Yeah, thank you also, and I wish you all the best with your studies.
Okay. Once again, thank you very much, Dr. Della, for such a beautiful presentation. We are very grateful. Please, at this point, any comments or suggestions before we bring the meeting to a close?
Good evening.
Good evening.
Thank you for the presentation. I just want to find out if we're going to have one more session. The pathologies that have been described, and particularly for those who have the cyanotic ones, so that you can just put us through all those various procedures. I think a number of them could be very helpful for MCQs, like the Fontan, Glend, BT, Balotoxic, shunt exchange. So I'm sure with the way it tends to explain, it makes it very graphical, and you might be able to put it in your head. So I don't know if we'll have the opportunity of having that class in the next meeting, because it seems that the next meeting will be the last that we have. So even though we don't have time to go back to review, we can go with any graphical representation we have today. Thank you.
Okay, thank you. That is also very important. So we would have to communicate that to Eugene, and then he can inform him and probably add a few things about those procedures.
So all the procedure from Ross to arterial venous shunt to all the 3 stages, or within node land, where you have all those 3 components, all of them, so that at least if you're asking MCQ questions, we'll be able to relate it to you without going to read it again. Thank you.
Thank you. Okay, please, any more contributions? Okay, if there are no contributions, then we'll pause here. Okay, so have a good night.
All right, good night. Bye.